Okay.
Perfect. Thank you.
Can you all see my screen?
Yes, perfectly. Part 5.
Cool. Thank you very much, Florian. That was very interesting, and hopefully that will tie in nicely the theme of steroids onto part 5 of our Osteoblast series. So let's press. So far we have done assessing the patient with low bone density. We've done interpretation of DEXA scans and how often, and we've done how to decide if a patient needs treatment in the FRAX score, and we also did renal bone disease at the very beginning. So today we're going to do a bit about steroids and bone, and also tying into the talks after mine, we'll talk a bit about hyponatremia as a risk factor for low bone mineral density. So how bad are steroids for bones? So here's a study published in JCM just over a decade ago, over 20 years ago. 9 eugonadal men, they were given prednisolone 50 milligrams per day for up to 6 months. And this is what happened to their bone mineral density. So just in 6 months, you can see a massive decrease in the bone mineral density, especially in the very trabecular bone, which is in your lumbar spine. Okay, so almost 5% in up to 6 months. And with that, there were also decreases in bone formation markers, such as, I'm just trying to hide this screen, such as osteocalcin and alkaline phosphatase. There were also suppressed sex steroids, but the ratio to the SHBG remained unchanged. There were no changes in the resorption markers CTX or PTH or calcium. So here's 9 healthy men, you give them steroids for 6 months and their bone density declines dramatically. And the effect is probably to a degree through sex steroids. So here's 33 patients post-surgery for Cushing's syndrome. So here we have too much steroids. So before they had their surgery, they had decreased bone formation marker, osteocalcin, and decreased bone resorption marker, CTX pre-op. And then it was compared to age, sex, and BMI matched controls and followed up for 6 years. So here are the patients. The upper graph is the spine, the lower graph is the hip. On the y-axis, we have the Z scores. And then going across with time, you've got their first and their second follow-ups over the course of up to 6 years. And you can see the Cushing's syndrome patients post-operatively had a dramatic improvement in their bone mineral density, both in their spine and in their hip. So that's more evidence that steroids are bad for bone. So marked improvement in bone mineral density after removal of this endogenous cortisol surplus. So here's a question for you. By what mechanism do steroids impair bone strength? Is it through increased urinary calcium, decreased gut calcium absorption, decreased bone formation, increased bone resorption, or decreased sex steroids? So I don't know if Kareem is going to...
Yeah, they've got it. They're already voting. I shall share the screen too, so you can see what they've chosen.
Okay, so most people have gone for increased bone resorption and decreased bone formation, and there's a good representation of people voting for decreased sex steroids. So the answer is all of those mechanisms in actual fact, and many more. So if I just can...
Do you want to share again? Yeah.
Yep, oh, do I need to click share again? Okay, so share screen.
Yeah, perfect.
So here are the effects of steroids on bone pathways. So in yellow, the osteoblasts, in white, the osteoclasts and osteocytes, which are the sort of conductors of the bone cells, the osteocytes, and then you've got other effects. So see, here you can see here, there's lots of effects through yellow pathways on the osteoblasts, lots of effects on white pathways on the osteoclasts, and there are the other effects such as muscle weakness, increased urinary calcium, decreased calcium absorption, and lower sex steroids. And this So as you can see here, you can appreciate there's multiple effects of steroids to impair bone modeling and therefore bone density and bone strength. Okay, so here's another study, also about 20 years old, and you can see here on the y-axis the rate of non-vertebral fractures, so fractures anywhere in the body apart from the spine, according to dose of steroids as prednisolone equivalent. So here you can appreciate that as the dose of the prednisolone increases, so does the rate of fracture. Unsurprising, okay? So increased steroid dose leads to an increased fracture risk. Now on this graph, you've also got risk of fracture on the y-axis, but here you've got their cumulative steroid dose, so how much have they received in total so far. Now the point of this graph is to show that it's all about the height of the dose, not the duration of the dose. So they all have the same cumulative dose along these sort of vertical sections, but the people who have the higher fracture risk are those who are on high dose. So high dose for a shorter amount of time is worse than low dose for a long amount of time, essentially, okay? So fracture risk predominantly associated with this higher daily dose rather than the cumulative dose. And you will all have read about dexamethasone, supposedly low-dose dexamethasone, 6 milligrams, being the magic bullet for COVID. And I've been involved at Imperial in designing the bone protection that has to go alongside that dexamethasone high dose for COVID. So here's another graph. So this is incidence of fractures again on the y-axis according to cumulative dose. And what I want to demonstrate here is that you have a high risk, but once you stop the steroids, so in the dashed line, that's the first year after stopping, the rate goes down a lot, and the second year after stopping goes down a lot more. So it switches off very quickly. So the effects drop off quickly on cessation. Okay. So at what point do you intervene in a patient who's on steroids? When do you want to intervene with bone protection? There's lots of different guidelines, all saying slightly different things, but essentially all with the same message that this is a special group that we need to take special care of. What I do myself is I use Frax. It does cover the 2.5 to 7.5 and over 7.5 milligram prednisolone doses. I like to treat early, so I have a lot of patients who have MS, for example, and they're going to receive their methylpred, and I will give them some bisphosphonate, perhaps IV zoledronate, before they receive that. So it's in the system early. And then there's also the point to appreciate that you can stop bone protection on steroid cessation. A lot of these bisphosphonates last in the bones for many years, so they will get ongoing protection, but the off effect of steroids is quite quick on cessation. So here's Frax, which we went through last week, and basically question 8 here is glucocorticoids. So basically you tick yes if the patient is currently or has previously been on glucocorticoids for 3 months at a dose of Pred 5 or more. Okay, 5 or more or equivalent. Then you tick that. And you can see here, this is the output you get. So this is their age and the risk of major osteoporotic fracture. Remember, that's the humeral fractures, spinal fractures, hip fractures, but doesn't include things like pelvic fractures and tibial fractures. And then there's hip fractures here. And you can see there's 2 X's basically. The top one is if the dose is 7.5 or more, and the green cross is for 2.5 to 7.5. So obviously a higher risk if you're on a higher dose. And with that, you can extrapolate based on your patient's dose what the approximate risk is and where it falls according to this red-green divide on whether to treat or not, basically with anti-resorptives, denosumab, or teriparatide. Okay, so you're all probably wondering, does the same apply for replacement glucocorticoids? So in patients, for example, with Addison's disease. So here are the studies that I can find looking at this precise question. And I've put them in a table here with decreasing dose of hydrocortisone. Okay, so you can see the older studies, well, this old one, their patients were on 37.5, which we now appreciate is probably supra-physiological, it's not physiological replacement. Here they found that the bone mineral density was reduced in the PM, meaning postmenopausal women. Here in this study in 2009, where the average dose was 30.1 milligrams, all of them had reduced bone mineral density. The same here, the dose is 30. Here it's still 30, still most patients, most postmenopausal women have a reduced bone mineral density. They also looked at pred versus hydrocortisone and found no difference using a ratio of 1:4, which we probably think is not the appropriate ratio these days. Then there's the Jodar paper, 30 milligrams, which suggested that there was no overall difference, but it did suggest that prednisolone was worse for bone than hydrocortisone. But note here the ratio is 1 to 3.7. We probably think the ratio should be something like 1 to 5 with Professor Miran and others' work. So here, I'm not sure we can really interpret much about this pred in that study. Then there's Zellison study in 94, only in men. So they think this effect may be partly due to them becoming hypogonadal, they think. Then Vipka Art in 2006 showed no effect at this hydrocortisone dose on bone mineral density. And then the Kurt study, which has the lowest dose, 21.9, which is probably similar to our 10.55, was what we sort of use these days in clinic, did not find any reduced bone mineral density, although the Z scores on average were negative. So that means that they are below average, but not abnormal. Because remember, abnormal for a Z score is less than -2 versus +2, and there was no difference between controls and this group. They also talked about lower Z scores for pred, slightly versus hydrocortisone. Again, the ratio was a bit generous. Okay, so the message here is probably little or no effect at the lower modern doses of glucocorticoids, depending on the study. Z scores do tend to be negative, especially in this 2012 paper, suggests there may be a very mild effect, but this is probably within the normal range. There is some evidence that prednisolone may be worse than hydrocortisone on bone, but modern ratio is really 1 to 5. So most of these studies, well, all 3 of these studies where they looked at it, the patients were on too much pred really for fair comparisons. Okay, so in summary, supraphysiological glucocorticoids are bad for the bones in many ways. You can lose up to 5% of bone mineral density in under a year of high-dose steroids. The dose is the key risk factor when administering steroids. There are multiple guidelines of what to do, but essentially you can use Frax, as I showed you, for supraphysiological doses. And you can do it when you're about to start a patient on long steroid courses, or we get a query from the respiratory team or the rheumatological teams regarding bone protection. Start the bone therapy early, get it into the bones so that when the steroids come in to attack the bone, you've already protected them. Okay, then once the steroids have stopped, you can probably stop your bone protection. For patients who are on just replacement doses, as always, we have to aim for the lowest appropriate steroid dose. Make sure they have an adequate calcium and vitamin D intake, and you can use Frax. If there's just replacement glucocorticoids, don't click yes, okay? But use, this is for supraphysiological glucocorticoids where you tick yes. Always look for other risk factors, because together with other risk factors, it may tip them over the threshold for intervention. Monitor the bone mineral density, and the key thing here is the temporal changes, so serial bone mineral density, to see it dropping or stabilizing post-intervention. And in some cases, you may consider hydrocortisone rather than prednisolone, but further data is awaited. So that's that about steroids. Now, just leading on to the next series of talks, I wanted to inform you about hyponatremia as a risk factor for low bone mineral density. So I don't know if some of you came to the BES meeting last year in Brighton, where Joseph Barlis from Georgetown University gave a talk about hyponatremia and low bone mineral density, which was very illuminating. He's done most of the important studies in the field. So here's one of them, published in 2015 in JCM. So it's a matched case control study, and they adjusted for as many variables as possible, but not for anti-resorptives, I've noted here, and they excluded hyperglycemia. And basically, you can see the top set of graphs is osteoporosis risk, and the bottom is fragility fracture risk. And you can see here, anything more than 1 is an increased risk, essentially. Yeah? So recent hyponatremia, 3 times risk of osteoporosis. Chronic hyponatremia, that was defined as hyponatremia, so less than 135, at least twice 1 year apart. And the recent was within 30 days. So you can see chronic hyponatremia, 4 times the risk. Then they use various regression models, and they got sort of similar results depending on whichever model they use. In this one, they combined chronic and recent hyponatremia. You can see 12 times the risk of osteoporosis. And similar effects are translated in the functional outcomes, so the fragility fractures. So as a result of this osteoporosis, they do get more fragility fractures in a similar pattern to above. So vast increased fracture risk in patients who have hyponatremia. So you may say there's a lot of confounders. They try to control for a lot of them as possible here. Obviously, if you've got low sodium, you may also be dizzy and you may fall as a consequence of that. Now, however, the important thing to remember is 1/3 of the sodium in our body is in our bones. So this is an important sodium reservoir, just as calcium. So 99%, as I mentioned in a previous talk, of calcium is in our bones. So a very large amount of sodium is in our bones. It's a sodium reservoir. And so studies have shown that sodium, the osteoclasts, these are the bone eaters, that resorb bone, they can sodium sense. So as sodium drops, there's increased osteoclast formation and activity to liberate sodium, to try and correct this sodium deficit. And this is independent of osmolality. These are done in cell culture, so this is not confounded by other medications or other comorbidities. Now, separately, so in cases like SIADH, it's important to note that there are AVP receptors on the osteoclasts and the osteoblast that can be disturbed in SIADH. And furthermore, very high urinary sodium, as you may see in SIADH, will lead to an increase in urinary calcium, and so you will basically drain away the calcium from your bones. So there are 3 mechanisms that have been so far identified whereby low sodium can result independently in low bone mineral density. So we've done all of these so far, and I'll be on next time in a couple of weeks to continue the series.
Thank you.
Very much.